appreciate everyone's flexibility with the breakout sessions of giving a little bit more time. So we're about 15 minutes behind, so we're currently scheduled for this to go from 9:15 to 10:30, but we can shift that to 9:30 to 10:45. So that's fine if you need that much time. So we'll go ahead and move on to the Country PPH action plans. So I'm going to introduce the moderator for this session. It's my pleasure to introduce Dr. Anne Beatrice Kihara, who is based in Kenya. She's the president of the African Federation of Obstetricians and Gynecologists, AFOG, and work includes to address PPH and hypertensive diseases in sub-Saharan Africa towards reduction of maternal and perinatal mortality. President Emeritus of Kenya Obstetrical and Gynecological Society, COGS, senior lecturer, University of Nairobi, and a member of the Kenya Obstetrics and Perinatal Care Guideline Review Committee. That's a lot. I'm glad that you I'm glad you had some time for us.
Thank you so much. Thank you so much, John. It's a pleasure to be here, and I'm really excited about addressing PPH, which has still not yet been dented, as we would expect in low middle income countries. Now we're having three eminent speakers, all from Africa. So we will start with the Tanzanian presentation. And I'd wish to introduce the Tanzanian presenter, who's Dr. Joseph Masenga. Dr. Joseph Masenga works with Japaigo, Tanzania as a maternal and newborn technical lead under the USAID funded project, USAID Boresha Africa, providing technical assistance to improve quality of RMNCH services in the Lake and Western Zone of Tanzania. So without further ado, so that we have time to discuss on our action plans for the countries, I will invite Dr. Joseph Masenga.
Thank you.
Joseph, I'm sorry, one logistic thing I'll interrupt, I'm very sorry, because I did not do this myself. When you come back, please make sure on interpretation on the lower bar that you click on that and select either English or French. You need to select one for us to be able to hear. Okay. Sorry, over to you, Joseph.
Okay, thank you, Dr. Anne, and thank you all for taking your time to just listen. And I would like to share some of the innovations that have been done in Tanzania. Next slide, please. Okay, so the outline will be looking at the background in terms of magnitude of PPH in Tanzania, and then we see the analysis to identify some of the gaps, and then looking into the interventions which have been undertaken. We'll share with you some key results, challenge, and recommendation. Next slide, please. So, so Tanzania, the maternal mortality for the past 15 years has been stagnant, and as you can see in the right side of the trend, for the last year, according to WHO, the mortality was around 524. Comparing to the 2015 demographic survey, the annual reduction rate was around 2.9%. So, and around 29% of the all causes were due to PPH, according to the Ministry of Health. And looking to the routine service for the past 5 years, the percentage of births that have been receiving uterotonic for prevention of PPH was around 90%, and the incidence was around 0.8%. So the National Strategic Plan for Reduction of the Maternal and the Newborn has been prioritizing strengthening the quality of care for the obstetric emergence in order to be able to combat all the possible causes of maternal mortality, including the PPH. Next slide, please. Yeah, looking to the geographical location for Tanzania on the left side, the map showing the Lake and Western Zone, the northwestern part of the Tanzania, where we are also focusing, which has a higher burden compared to the rest of the part. Also, some part of the eastern part of the Tanzania. So as you can see on the right side of data in the lake zone, also showing the hemorrhage as the leading cause. Next slide, please. So just to share with you some of the gaps that were found in the lake and western zone, the northwestern part of the Tanzania in terms of PPH. So on the emergency readiness, and then we have found the team. We are not readily available, and especially during night and weekend. But more importantly is the role of the team member in each shift, whether it is the day or night. The role were not clear in terms of who is doing what during a shift. But also we were able to find a challenge on the commodities, the emergency commodities. Their supply was, the availability was inconsistent in terms of emergency, that these things need to be available all the time during the emergency. But also in terms of referring the patient were not stabilized prior to the referral, and also the notification prior to the referral to the receiving site so that they can be ready to respond to emergency was not also a practice. Looking into the skills, we were also able to find the gaps in the managing obstetric hemorrhage, and also including the skills in managing PPH in cesarean birth. We were also able to see the critical shortage of the human resource for Earth, and this case particularly were midwife, doctor, and anesthetists. Looking to the S system for the element of maternal perinatal death and response, despite the low quality of the review itself, but also the more challenging part was the response to the recommended action that are coming from the review process. We have seen also the shortage of blood and blood product in the transfusion site, and also the more important is the leadership of the facility in terms of managing staff, planning, allocating resource based on the need, and also depending on the recommended action was also a challenge. Routine service delivery organization as a way monitoring of the postpartum women, the immediate postpartum care was also a challenge to the extent that it came to the delay in identification of the PPH cases. For the facility and community linkage, we also observed gaps in terms of rate referral from the community, which create a delay in health-seeking behavior. Next slide. So we are undertaking some of the intervention, at least try to address the gaps that have been identified. One of it was adaptation of PPH framework, and in terms of first updating the national electronic guideline to include the last recommended for WHO, but also we included the use of tranexamic acid in management of PPH in Tanzania. For the facility readiness, we were able to train the team, just try to create the team in the facility to ensure in each shift, whether it's a day or night shift, there is the role are very clear who is doing what in terms of the leading the shift, someone who is ready to check the commodity. Example, if they know, do we have a blood, do we have a fluid, in terms of someone to taking care of the communication within the facility, so that in each shift the team is ready to respond on emergency. But also facilitating this team also to have a regular emergency drill in terms of improving their capacity to be able to respond on emergency, specifically handling the hemorrhage cases. But we also focusing on improving the communication among the facility. So in this area, we had an intervention called closed user group, the CUG, where the health facility are connected in terms of we have a network of the facility. They are connected. We supply them with a mobile phone, which they can call for free in terms of prior notification, but also they can consult during emergency, and to the higher level center, they can provide some of the technical assistance prior to the referral. Improving the capacity also of the service providers, we observed in the gaps. So our blended learning which is driven by the data in terms of on-job training, which is a modular training for the PPH, using the Help Mother Survive approach. And also we have for the sites that are providing surgery, training them on management of PPH during the cesarean section, for example, using the bearing suture, but also to ensure that we have an ongoing practice at the facility. We have a structured regular peer practice as a team at the facility. They continue to practice, and this is ensured by having one person we call them peer practice coordinator, who can coordinate the continuous practice to ensure that a provider continue to practice to improve their skills. But our mentor, to support the ongoing performance of this facility, we continue doing the targeted support, supervision, and mentorship to the facility, which we identified to have poor performance through use of data. But also we integrated the digital learning to improve also the learning. And here we have an e-learning platform where we uploaded the modules, and the service provider can access this using their smartphone for continuous learning. And in terms of strengthening the health system, we have some of the accountability measures to make a system responsible to the gap. And one of the accountability measures that we are currently using is the MPDCR, where the facility leader are being accountable to respond on all recommendations and ensure a strategy for follow-up that these recommendations are being implemented. But as you can see from the previous slide, in terms of the gap, the other accountability measures that we are using is community scorecard. In this approach is where the communities themselves, they identify the issue in terms of maternal, of course, and newborn deaths, where the issue are happening, and then they identify the root cause, setting some of the action, and each member in the community is accountable to respond on the agreed action to ensure that the situation is changing. And also we have been collaborating with the Ministry of Health to have a guideline for the leadership and governance across all levels of care. And here we are strengthening the facility leadership in terms of training and mentorship for them to be able to understand how in terms of planning, allocating resources based on the need, try to have a good accountability measure to make a follow-up of the recommended action, but also looking into the ensuring the availability of blood, but not only available, but quality blood and quality blood and being accessible. So next slide, please. So these are some of the key results. Next slide. So for the past 3 months in a project, since the project started, we have seen facility delivery increasing, which is now around 85% of the delivery are happening at the health facility. But the good enough is those facilities that are happening at the facility, the best that are happening at the facility, around 95% of them are receiving uterotonic for prevention of the PPH. And we have seen the decreased trend of PPH incidence, which is less than 1%. Of course, in the next coming slide, I will present some of the challenges in terms of reporting the PPH. Next slide. We also are tracking the case fatality rate for the PPH at the 2 CMOC sites in the Lake and Western zone of Tanzania. And as you can see, we started with the 38%, but due to gaps that have been identified. Some of the facilities have been added, and as you can see, it shoots up to it has shooted. And then what was important is that I just want to highlight in this slide that for these facilities that have been added, we have identified more gaps, and we are strong working to address gap for this health facility with more challenge. Next slide. So as I said on the previous slide, that we trained the district blood collection team to ensure that the blood is available at the transfusion site. So for the past 4 years, we have at least attained around 66% of what is required to the transfusion site. And the zonal transfusion center are currently trying to improve that, to ensure that the site, once they send the sample, they get the result on time and ensure the turnaround time is minimized. Next slide, please. So there are some of the challenge. One of it is PPH, which is underreported, and we are struggling to improve the situation. We have observed that most of the PPH which are managed in using the first line with the protonic, which are not severe, are being underreported. And also the still experiencing challenge on implementation of the process in terms of responding to the recommendation. And this particularly linked to the facility leadership being accountable to respond on those recommendations. We still also are seeing severe shortage of staff, as I said earlier, and particularly the anesthetist and also the midwife. And for the last year, the evaluation found that we are around at 50% of the government establishment. Still, we see a suboptimal implementation of quality of care intervention at the health facility. Next slide. So based on this, we commend our national strategic plan in reduction maternal mortality to focus on PPH and specifically improving the quality of care and in terms of prevention, detection, management, and as we did updated the guideline to include some new innovation like tranexamic acid in the management of the PPH. Of course, we already included this into our national guideline, but here importantly is to ensure that it is implemented across the country. The metrics also for monitoring quality of care of PPH, for example, percent of PPH who are correctly managed with Rototonic, which will help the implementation and also intervene where there is a gap in terms of quality of care, but also the importance improving the referral, as we've seen also one of the factors that are contributing to the high number of deaths due to PPH. So specifically in terms of strengthening the transport within the community, but within the, as we explained earlier, and also follow up of the outcome of this referral. So in terms of also improving the facility readiness, which is also important, leave out despite the working on the team, ensure they have a role, but most important two aspects of life-saving commodity, ensure they are viable, but also the human resource for health to respond with these emergencies. The surgical management, as we've seen, and also the data in cesarean section management of the PPH need also to be taken into account as some of the PPH due to cesarean section are now coming up in Tanzania. Strengthen the response, but also the follow-up of the recommended action and to ensure that the managers at the district and also the facility addressing all the challenge in terms of implementation. The community engagement as a social accountability measure, as explained, the community scorecard need also to be taken into account. And lastly, the pre-service curriculum for Tanzania for midwife doctor need to include the updated PPH protocol and clinical simulation drills for team building to respond on the PPH. So with this presentation, and also lastly, I would like to thank the USAID for their support in terms of fund and technical support, making us to implement all this innovation in reduction of the deaths due to PPH. So thank you.
Thank you, Dr. Joseph Masenga. We really appreciate your presentation. To the participants, I will please request that you put all your questions in Q&A. We will address them at the end of these 3 presentations. So I will move straight on to Dr. Priscilla Firi Mwanza. She's a consultant OBS-GYN, head of OBS-GYN in the Ministry of Health, Kamuzu Central Hospital, Malawi. So Priscilla, the stage is yours. Please go ahead.
All right. Just let me... All right. Thank you, Anne, and thank you to Tanzania for the first presentation. At least it was our neighbor starting. So I think just to highlight where, to give people idea of where Malawi is. Malawi is bordered by Tanzania, Mozambique, and Zambia, so that people can just get an idea of where we are. We are in the southeastern part of Africa. Next slide. So Malawi has one of the highest maternal mortality ratio at 439 per 100,000 live births. This is according to the Demographic Health Survey of 2015 to 16. 2% of women in Malawi are more likely to die from pregnancy-related causes in their reproductive lifetime. And the leading cause of maternal mortality is still postpartum hemorrhage. Malawi joined the WHO Quality of Care Network in 2016, and our target by 2022 is to halve the institutional maternal deaths. Next. So this just shows the trends in maternal mortality ratio in Malawi according to the Demographic Health Survey. As we can note, from 1992, initially we had a rise in maternal deaths, and then we started seeing a steady decline from 2004 to 2015. This is partly due to the reduced fertility rate, which was 6.6 in 1992 to 4.4 in 2015. And this is due to actually increased uptake in contraception. And then also the other reason is that we moved from using traditional birth attendance. So government in 2007 introduced a policy whereby it banned traditional birth attendants from providing delivery services, and then started promoting skilled birth attendants. So it is noted that in 1992, institutional deliveries actually increased from 55% in 1992 to 91% in 2015. And skilled birth attendants increased from 55% in 1992 to 90% in 2015. Currently, from the 2015 demographic health surveys, home deliveries have been reduced to 7%. Next. So some of the action plans, some of the things that are done in Malawi in order to prevent, manage PPH include: 1, prevention of anemia. We all know that a woman who is anemic is more likely to decompensate after bleeding if they have PPH, even after losing a little amount of blood that is less than 500. So the first thing that is more important is screening for anemia in pregnancy. the main stay of screening is hemoglobin, using hemoglobin check using hemoglobinometers. This is because most of the places in Malawi, most of the hospitals are not able to do full blood count. And even though hemoglobin checks are common in some places, you find that other places, electricity, are finding it difficult to check hemoglobin. And also, because of lack of supplies, such as cuvettes, you'll find that some women will still not be able to get their hemoglobin checked. So Malawi adopted use of the WHO hemoglobin color scale in order to ensure that most women are screened for anemia. And then we also do iron supplementation, just like in the WHO recommendation, intermittent preventative therapy for malaria using SP, deworming of all pregnant women in the second, starting in the using albendazole, and also insecticide treated mosquito nets are provided. We're still not doing so well with some of these interventions. Although it is reported that 87% of women receive iron supplementation in pregnancy, you still find that most women still report with anemia in pregnancy, and the prevalence of is between 52% to 72% in Malawi. And most of it is iron deficiency anemia. Then for intermittent preventative therapy, about 80% of women will get at least one dose of SP in their pregnancy. But we all know that for someone to effectively prevent malaria, you need at least 3 doses of SP, and only about 30% of women received 3 or more doses of SP in the 2015 Demographic Health Survey report. 52% of women received albendazole, and it was reported that 57% of women received or reported having an insecticide-treated mosquito nets in their homes. But having it does not necessarily mean that using it. So we still see women reporting with malaria in pregnancy. So intervention number 2 include prevention of hemorrhage in high-risk women using uterotonics. We have national guidelines that are produced by the Ministry of Health, Reproductive Health Department, but we also have the Association of Obstetricians and Gynecologists of Malawi, which starting from 2015 started producing guidelines and protocols in obstetrics and gynecology, and so far we've produced two versions, the second version coming out in 2017. And from the AOGM guidelines, we encourage prevention of hemorrhage in high-risk women, for example, grandmatiparas or twin gestation, or those that had macrosomia and all, by using 20 international units of oxytocin in 1 liter of normal saline to run for 6 hours. Or in places where oxytocin is not available, then we encourage oral misoprostol 600 microgram as a start dose. So this is only in high-risk women. Then we also have the national protocols of management of PPH, which are produced by the Ministry of Health, Reproductive Health Department. And when we're doing our national assessment, we make sure that all labor wards and antenatal wards actually have these protocols posted up in their wards. When you go for assessments, you actually notice that most people are able to know about the protocols, but you still find that sometimes people, I don't know whether they forget or they know what they're supposed to do, but sometimes there's just like, it may be negligence or reluctance or not having the zeal to act in a timely manner, that some of the things might have been missed. And mostly some of the reasons include not being able to work in a team setting. For example, you may have someone calling for a PPH and you find that some people are doing other things. Maybe it's just one person or two people managing the patient. And then there's also use of tranexamic acid. So far, all of the tertiary centers have a good supply of tranexamic acid, and a few district hospitals also have started procuring tranexamic acid and using tranexamic acid, but some other districts are still lagging behind. They haven't yet incorporated the use of tranexamic acid in the management of PPH. And next. And then condom balloon catheters. In most of the trainings, including that are done in Malawi, and also the trainings from AOGM or the College of Medicine, encourage use of condom balloon catheters. I'm going to talk about that in some of the projects that are being done. So I would say most central hospitals, district hospitals at least, are able to do condom balloon catheters. We do not really encourage condom balloon catheters in BMOC sites. At least CMOC centers do provide condom balloon catheters, and it's mostly because of ease of being able to do that. And most of the times we encourage people to do this in a theater setting, whereby if the condom balloon catheter fails, then you're able to do a laparotomy. Then we have the prevention of hemorrhagic shock using non-pneumatic and shock garments. Almost all health centers, including primary healthcare facilities, do the garments, and we encourage them to apply the garment before the woman actually goes into hemorrhagic shock. And most women who have PPH are actually transported on a nursing. And once they reach the referral center, the receiving center, we exchange the garments. So when the patient is delivered at the center, we give them a replacement of their garment. And UNFPA has actually helped a lot in distributing the garments to all health facilities in Malawi. Then we have capacity building efforts. So there are short-term projects and long-term plans in the capacity of health workers. So of note, I'll start with the IMPACT project. So IMPACT project is a Canadian-based project. It's actually integrated pathways for improving maternal, newborn, and child health. This project started in 2016 and is running for 5 years. And the objective is reducing maternal, neonatal, and child health through capacity building. The implementers are, the donors are Canadian government and others, but the lead implementer is Coata Development Consultancy in consortium with Society of Obstetricians and Gynecologists of Canada, Plan International Canada, Malawi, and also Association of Obstetricians and Gynecologists of Malawi. This one is one big project because it involves mainly 3 districts, but it has managed to train almost all health workers in these 3 districts. And apart from just providing training, they also do provide resources, including ambulances. For example, one district hospital can get up to 6 ambulances, which helps a lot in improving the referral system. So apart from PPH is a big part of the topics that are taught in this project, but there are also other topics such as sepsis, hypertension, preterm labor delivery, and other things. Then we had the M project. This is American College of Obstetricians and Gynecologists Alliance for Innovation for Improvement of Maternal Health. The M project was started in Lilongwe, Kamu Central Hospital, and the surrounding health centers. This was in 2017, and mainly it included programs. It included things like classroom didactics on obstetric hemorrhage, teamwork protocols, skills laboratory activities, and simulation training. The procedural interventions that were that were provided during this training include use of condom balloon catheters, the non-pneumatic and shock garment, uterine artery ligation, and billing sutures. So health workers were actually trained on these skills. And in 2019, an evaluation study was done to see if there was any improvement in maternal mortality and patient hospital safety culture scores. And the results of that study actually showed that there was a significant reduction in obstetric hemorrhage, related deaths from 1.2% to 0.2%, which was a relative decrease of 82.1%. Then recently in July, there's the Advanced Care for PPH project, which is a USAID-based project running in 25 centers in 2 districts. And so far, they're using the Pronto curriculum, and so far they've done a training of mentors, and the project is ongoing. Then we have long-term capacity building efforts, including the University of Malawi College of Medicine providing training programs, and these include the Bachelor of Science in Obstetrics and Gynecology, which started in 2013. This is, the entry criteria for this program is actually clinical officers who have a diploma in clinical medicine and have been practicing obstetrics and gynecology. So these are health workers who already have the skills in obstetrics and gynecology, but the training aims to actually reinforce and strengthen their skills and improve their knowledge in the management of women, pregnant women. And then we have the MED program. The MED program was started in 2013. The aim was to increase the number of obstetricians and gynecologists in Malawi, because so far we only have 42 obstetricians and gynecologists who are Malawians. And we have 27 districts in Malawi, but only tertiary centers, which three tertiary centers have obstetricians and gynecologists. The aim is to have actually at least 1 obstetrician and gynecologist in every district. So far, the progress since opening the program, we have trained 12 obstetricians and gynecologists. We hope to train more in the future. The challenges that the program is facing is unwillingness of people, like people are not interested in doing obstetrics and gynecology. Maybe they think there's too much work because of the increased patient doctor specialist ratio. But we're still campaigning and trying to coerce more people to actually to join the program so that we produce more obstetricians and gynecologists. So the challenges mainly in the management of in initiating and implementing these action plans lies in the number of the human resource that we have. Most health centers, the biggest challenge is in the number of anesthetists that we have. You have that one CMOC center will only have 1 anesthetist, or even a district hospital only having 1 anesthetist. And this anesthetist is working day in and day out for let's say 2 weeks. At the end of the day, they'll burn out, and you may find that they've just started referring patients because now they are tired. And also, sometimes you find that a center that is maybe doing 80 deliveries in 24 hours only have 4 nurses on duty, or a center that is doing, let's say, 20 deliveries in 24 hours only has 1 nurse per shift. This adversely affects the health outcomes, because the health workers tend to have burnout and they may not work as effectively as they should. And other challenges that are encountered include erratic supply of erratic supplies of drugs and supplies, and drugs including blood and blood products would also be classified as drugs. So most in Malawi, the culture of donating blood is not that much. We usually depend on young people who are secondary school students, and in times when they're on holidays, you'll find that the supplies of blood are really on the lower side. And you may find that most women, maybe health workers, know what actually to do, what they would. You still find that women are dying because there's literally nothing, no supply of blood or blood products. And the other challenge that is there is poor data collection system. Our demographic health information system usually underreports most of the cases. For example, just as an example, in the 2018 report, you'll find that the events of PPH were only 151 out of 550,000 deliveries. That's like very, very underreported. So we actually need to improve on our data collection system, documentation, data collection system. Actually, we're in the talks with the quality department so that we should have an electronic system of collecting data, and have actually hire people who would work on inputting into the data system so that good quality data. The other challenge that we have is lack of implementation of the plans of the maternal death surveillance reports that we get. You'll find that people have done the audits, and they've recommended some interventions to be done, but implementation most of the times is not done. Thank you. But otherwise, in terms of the opportunities and successes that we've had so far in management of PPH include an improved referral system. We have a WhatsApp group in all the 3 regions, and before referring a patient, referring centers are actually encouraged to either post on a WhatsApp group if they haven't gotten an immediate response, to actually call the consultants or the teams on call on the other side, because call routers are actually provided through the WhatsApp forums. So you actually have someone from a referring site actually calling you to tell you that they're sending someone, let's say with PPH, and the people on the other side can actually prepare, asking the blood group of the patient, and prepare for the blood and blood products before the patient arrives. So this is actually a good, this is actually a successful intervention that actually improves the quality of care that is provided. Thank you.
Thank you, Dr. Priscilla Phiri. Thank you very much. You've given us very good insights, particularly on prevention. Now I'll move to the 3rd presenter, who's Dr. Gadhari Dirango. He's from Kenya. And I'll give a brief synopsis of what he has given as his bio. He is a family planning, reproductive, maternal, newborn, and adolescent health specialist with over 20 years of experience in health system strengthening, technical support, service delivery, research, and program management in sub-Saharan Africa. Currently, he is with the Family Planning and Reproductive Health Technical Lead at Pathfinder International, working for the USAID funded Momentum Integrated Health Resilience. He recently transitioned from JPIGO, our collaborative host, where he was the Chief of Party and Technical Director of the USAID funded Afya Halisi project in Kenya. He has also served as the Technical Director of MCSP in Kenya and Zambia. He is passionate about implementing cost-effective quality interventions to end preventable deaths of women and children in low-middle income countries. So I'd wish to welcome him to make his presentation. Please post your questions so that we can address them at the end, immediately after his presentation. Thank you.
Thank you, Dr. Ann. Just to point out that I have no conflict of interest. And if you can go to the next slide, please. Point out that Kenya, has similar really issues like what the previous presenters have given regarding their counties. I just point out that Kenya is situated in a unique geographic location where it is bordered to the south by Tanzania. We have a huge border with Tanzania, and an opportunity there to see a lot of wild beast migration around this time of the year when wild beasts migrate between the two countries. To the west, we are bordered by Uganda, and with Kenya, Uganda, and Tanzania, we share the largest freshwater lake, Lake Victoria. To the south, to the northwest, sorry, we are bordered by Southern Sudan, and to the north by Ethiopia. We also have a huge border with Somalia to the east, and to the southeast is the Indian Ocean. Again, an opportunity to enjoy our beaches. The reason why I'm talking about the geographic location for this is also to point out that Kenya has a two-level governance system where you have the national government and 47 devolved units called county governments that are responsible for provision of services to health services. Of course, using policies, standards, guidelines that are developed and disseminated by the national government. The other thing is to notice that there's a huge commitment to reduce maternal mortality ratio from the current level of around 342 per 100,000 women to less than 200 by 2030, in line with the desire for the global maternal mortality ratio to go below 70. Next slide, please. I also want to point out that we made tremendous strides in reducing maternal mortality from rates of about 500 per 100,000 women to 362 in the 2014 DHS, of course, presenting the 7 years preceding that. And next slide, please. And also more currently, the data that we have are demonstrating about 342 mortalities per 100,000 women. But of course, still unacceptably high. And so taking opportunity of the many interventions that are available. Next slide, please. And also to point out that the biggest cause of mortality, like have been mentioned in many low and middle income countries, remains as hemorrhage, obstetric hemorrhage, and it is responsible for deaths, for every 10 deaths, 3 to 4 of them as a result of bleeding after birth, of course, is the commonest reason. But also, again, point out that we have had opportunities in addition to the routine MPDSR, maternal and perinatal death surveillance and response. We have also had the opportunity to actually have confidential inquiry into maternal deaths. We had one that gathered data from 2014 and was published in 2016, and we have another one that has been published. Is being worked on in terms of publishing. And we know that out of that, we've also seen a huge opportunities to engage beyond the healthcare system, but the political and policy leaders in terms of having the conversation around how we can be able to improve the health of women and children, and of course, reducing maternal mortality from hemorrhage and of course, from other causes. Next slide, please. And I think just to point out from the confidential inquiries to maternal death for the 2019 that's being published, is that a lot of issues are related to in health, the health resources for health, human resources for health, in terms of ability to initiate care appropriate care in a timely manner, and also from many other reasons, so that you notice that 9 out of 10 deaths that from the confidential inquiry were really associated with some factors that had to do something with the health workforce, which is a little unfortunate, given that women would come to us to then be able to get the most appropriate care to save their lives, not only save their lives, but allow them to thrive. Next slide, please. But out of that, we've also been able to see some of the actions being put in place, including making sure that there is commodity security related to not just oxytocin and making sure that there is a cold chain for that, but also misoprostol as necessary. But more recently, beginning to talk about histobocarbetocin, and we expect it to begin, become available soon in the country. It's already in the essential medicines list, and we do begin to see that as being an opportunity, especially in settings where we know the cold chain for oxytocin is a challenge. And I know we've talked a lot about histobocarbetocin. Of course, in terms of capacity building, making sure that the leaders, the specialists, the obstetrician gynecologists, are beginning to are more intimately involved in building the capacity of other cadres of healthcare workforce through mentorship, competency drills, and any other competency-based training, so that then we can be able to improve, the outcomes related to our the intervention that we do provide. I think, again, the other thing is also the private sector being a very heterogeneous sector. The private health sector is also a very important avenue through which women and their families seek services. And I think it's also important for us, and we've been in the government is leading initiatives to make sure that they're involved. Their skills are up to speed. They're also able to report. And we are working with the specialists, including the Kenya Obstetrics and Gynecological Society, to get a little more involved in terms of building the capacity of the workforce across, both the private and the public sector. The other thing is, of course, making sure that, and I know that this has been mentioned, in part of the country, especially because of geographic location around the lake region, disorders like malaria, making sure that then we're able to provide intervention to prevent that or reduce that, and make sure that you reduce maternal anemia and other comorbidity, including HIV, that you all know affect adversely outcomes, including those related to bleeding after birth. Next slide, please. I also want to point out, even as we go along, is that in the COVID-19 pandemic also has opened another opportunity for us, despite the challenges that it has created in terms of perhaps women reducing or not accessing care as much as possible. We've also, especially antenatal care, although we've seen that in terms of skilled birth attendants, there has been not a significant difference. But I think it has also provided an opportunity for the country, including the political leadership and everybody else and the public, to start talking about health, including health of our women, health of our children, so that we're able to manage both elements. The health workforce, being able to talk about the health workforce as to what they need to be in terms of their skills, but also beyond that, being able to have packages that are appropriate for them in terms of incentivization and motivation for them. And I think a lot of it revolves around the quality of care. So we are seeing, and Dr. Kihara talked a lot about the quality, the guidelines that are being developed, several of them, the quality of care network, and many other things, including standards guidelines. But I think the more important thing is to make sure that they are disseminated appropriately in a timely manner, and also implemented as soon as they are. And also then being able to find ways and means of getting the data, so that you can be able to evaluate what is coming out of the things that you're doing. Next slide, please. I think the other thing, and this is again related to some of the things we've been thinking about in terms of, we talked about a lot about reporting and making sure that there's quality data, but also beginning to think what are some of the things that we can be able to report that speak to quality of care, so that other than just talking about skilled birth attendants, talking a lot about the quality that is provided, including arms tale in terms of making sure that then women who come and give birth, they get active management of that stage of labor as described in our guidelines and standards. In terms of antenatal care, making sure that they don't just come for the visits, but they actually get services that would speak to quality. And of course, in terms of making sure that there's elements like EMONG, these things are actually spoken to in terms of the things that they actually get in terms of quality of care, indicators that then can be able to be utilized. Next slide, please. In terms of, again, not just talking about successes, I'm not saying that there are no challenges. There have been quite a huge number of challenges, but some of them can also, the flip side, actually opportunities. One of them, especially the evolution of health services, has given the opportunity, for services to be closest to the people as much as possible. But the flip side too is that some of the counties, because of devolution, the fact that some counties, are still struggling with figuring out. This is something that began in 2013. The actual implementation began in 2013. So we are still in the learning phase. Some counties have been able to do remarkably well, but there are some that are still lagging behind, including ways of incentivizing their healthcare workforce and sometimes having unnecessary squabbles that lead into strikes, of course, denying women services. I think the other thing is of also bringing in the broad range of non-state actors, including NGOs, but also, like we mentioned earlier, the private sector to the fore, so that we can all begin to be talking about the same. But even as we talk about the HRH and the challenges that we do see in terms of their skills and competencies, there's also the other element of deployment and distribution, which you also need to be speaking about. And there's a very rich conversation going on in the country. Universal health coverage and free maternity care, of course, provide additional opportunities with resources that are going down to the counties for implementation. We talked about our reporting, the district health information system, to making sure that then you're able to capture indicators relating to PPH. And there are a lot of conversation in technical direction, at technical working groups at both national and subnational levels, guidelines in place for use of tranexamic acid, and again related to quality, so that even as things win, even the new technologies come, new innovations come in, they are fighting an infrastructure, a system that is already available to be able to begin being utilized. But like I said again, is that some of the things, you're still not out of the woods. I think you're still seeing a lot of unnecessary and preventable deaths that we could actually be able to minimize if only we're able to implement some of the things that we've been talking about. Because this is a country that has been on the forefront in terms of developing, translating evidence to policy and practice, but also making sure that you're utilizing that. We're also happy to see that there's a lot of conversation around managing PPH more broadly, including other private players, projects coming in to be able to tap into that. And then with that, also being able to see how can we improve our reporting system, so that then whatever is being implemented, you are actually able to ask ourselves what kind of impact it is leading to. And yes, I want to stop there and appreciate and being given this opportunity to speak to Kenya. There are a lot of things that really have been happening, but like we say, you still have a lot more to do. But you are happy and delighted to see, especially the political and policy environment that is very favorable, and being able to utilize that. Like I said, COVID-19 also, we are beginning to see the opportunity. Of course, there's a lot of adverse things, there are a lot of bad things about COVID-19, but you're also trying to look in there. There must be a silver lining that we need to utilize. And I think the bigger conversation is resources now being able to flow a little better down to where they're needed. Next slide then. Thank you very much.
Thank you very much, Dr. Dirango. I will move straight to the question session, but I think I will also give my contribution from another perspective. But let's start with the first question, and this is directed to Tanzania. What are the key success factors that have led to the doubling of access to safe blood between 2016 and 2019? Please enlighten us. We've heard the Rwandan story. Maybe we can begin to hear what the Tanzanians are doing. Tanzania?
Okay, thank you, Jeff, for the question. And yeah, so for in the previous year before 2016, the system for blood collection and also distribution was central, using the zone, which was the responsibility for collection, testing, and also distribution. But from 2016, this was decentralized, into the district level, and then with the decentralization has was in the process of training of the district blood collection team, which included some included of the laboratory technologists and some of the other members like social welfare to be able to have a collection, and then they had a collection plan on monthly basis, which is also integrating the transfusion site team, but also the and also so now the transfusion center are responsible to collect the blood together with the district collection team. They only send the sample to the zone, and then the zone they send back the results to electronic platform. So this decentralization is the one that made achievement as we have observed.
Okay, thank you very much. The other question is, have you added heat-stable carbetocin as an alternative for preventive management of PPH?
Okay, thanks again for the question. The current guideline that was updated last year has no inclusion of heat-stable carbetocin. However, a discussion already started through the Safe Motherhood platform to include it into the to update into our guideline as an alternative, of course, taking into consideration of the challenge that we have in terms of storage capacities.
Okay, thank you. From the next question, this will be directed to Priscilla. Has procurement been enough to increase the use of tranexamic acid? Do providers feel comfortable using tranexamic acid? Are midwives authorized to use tranexamic acid? This really speaks to the regulation and also the scope of practice for practitioners.
Okay, so providers do feel comfortable to use tranexamic acid. Midwives are allowed to use it, and most of the time they even initiate it before even the doctor arrives. The challenge is with the erratic supply, like the procurement. There are times when you would not have like the IV tranexamic acid, and alternatively, patients are given the oral one. And at times as well, whereby we have no supplies at all. So the supply has been erratic, but every time when it's available, it's offered to the patients.
Okay, this other question is open to everybody in the panel. What have been your experience with the use of tranexamic acid? Does the data show that it has minimized death or morbidity? So any one of you can respond to that. Any one of you?
In my country, in Malawi, we don't have any data. As I said, data is a problem. We haven't done any audits on the use of tranexamic acid, so I wouldn't really.
Okay, maybe I can bring in the Kenyan experience. We were engaged in the woman trial, and it was very evident, as long as the tranexamic acid was given within 3 hours of the bleeding episode, it definitely reduced the morbidity and mortality that women were experiencing. I would actually refer you even to that publication, which is readily available in the Lancet. This is Sawaraj. Could you please explain a bit more about non-state?
I wouldn't comment on that.
Okay, please go ahead. Go ahead. Hello, who? Okay, Sawaraj also asked, could you please explain a bit more about non-state actors? This is for Dr. Dirango.
Thank you for that question. I think it's wonderful and very beautiful. I just want to point out that in the country, of course, there has been a lot of not just the government, but other players, including development partners, being able to come together and identifying and working together with the government to provide support to the government.
Sorry? Dr. Dirango, please go ahead.
Okay, thank you. So being able then to come together and identify what are the greatest needs of this country, what are the priorities, and then being able to put the resources and investments where they are needed most. I think from that, we've also seen a lot of NGOs, both local and international, in terms of the civil society organizations, being able to come together and galvanize movement. I think from that too, we are beginning to see a lot of events around social accountability, women groups themselves, right from the grassroots at the community level, being able to then step in and see how can the system be able, or the government, both the public and private, being able to provide services that are of quality. We've had, including agencies like the Kenya National Health Rights Commission, Human Rights Commission, also being able to be present. We've seen a lot of, again, even entities taking the government to court in the event that they are not providing service. And as appropriate, like we said, there has been a lot of missed opportunities in instances where commodity security is not guaranteed, including a simple drug like oxytocin in some counties. So being able then to stand up and ask, you as a county government, what is it that you're doing to provide for us? Right now, we are faced with a crisis for blood and blood products. We know that, and the pandemic has not made it any easier, but being able to even step out of the government, the state agencies, but being able to have a force that is outside this to be able to ask questions and being able to demand accountability from the government. I think that's basically the essence of this, being able to see that we are not just working, the government or whoever is providing services are not just working in a vacuum, but they actually have to work in a way that they also know they are accountable to the population, the citizenry of the country. Thank you. Over. Over to you, Dr. Ann, and your microphone is mute.
Oh, sorry. Within the community context, self-care. We know in the PPH bundles, the first is prevention strategy. When we think deeper, there should be a more holistic approach. We seem to just concentrate on anemia and the fact that you do have comorbidities, but basic things like WASH, which then inform warming programs, which then inform a supplementation or nutritional advice and provision. So the question is, should we continue looking at PPH as a medicalized entity or take a more holistic approach where we look at the woman, and including one question here that even speaks to the adolescent. Once you have the menstrual hygiene management issues, that is a girl who has started bleeding. Iron is a major problem. And cumulatively, birthing intervals that are too soon, too often, too frequent, that start very, very early. I think we need to have that conversation that would then speak in a more holistic manner on prevention. Maybe one of you can comment, and particularly the Malawi presenter, Priscilla, who spoke very strongly on prevention strategies. Hello? Priscilla or Gadari?
Yeah, if Priscilla is not available, let me just point out that I think Dr. Ann, you allude to point out very important things. Self-care as an entity, as an element that we enable to be able to bring. In addition to this, just making sure that women own their health, and not just women, it's women and their children, their families. I think we've also been able to see that through group antenatal care, being able to see how that brings together women to understand what it is that we provide at antenatal care, but then being able to hold each other accountable, so that when you go home, you've been given this iron and folic acid supplementation, you're actually able to take it because you have a partner, a buddy that you're working with. I think in addition to that, of course, there's the element of availing misoprostol beforehand for women in the event that they do not get to a facility in terms of delivery and swallowing, to prevent PPH. We also do recognize the fact that, and you speak a lot, especially with adolescent health. What you've seen is that in this country, we've seen a lot of, an increase in adolescent pregnancy, or at least you're speaking about it. But what we've also seen is that in some of the counties, when you put in a toll-free helpline, people, young girls and boys are actually calling. What you're seeing is that young girls are calling to ask a lot about questions about menstrual hygiene, especially the ones that are age 10 to about 17. But the older adolescents, 17 to about 19, you're seeing them actually talking about contraception and family planning. So I think there's an opportunity here that even now, and this is was again, we began this because of COVID-19, trying to see how we can be able to step in and overcome the challenges of COVID-19. But we are seeing that there's an opportunity that is bringing that conversation. We're already beginning to see what girls and women do need. And I think we need to be able to step in and provide those services that are responsive to them. We are also hoping that, like you said, now with COVID-19, improving hand hygiene and wash in general, hopefully it will improve the well-being of the woman and her household, so perhaps minimizing anemia and also minimizing PPH. And I think even as they come to the health facility, the formal health facility, I think we need to make sure that even as they are the community, they are being able to implement it. But when they come, we complement that and remind them to, so that when they go back, they can also become agents of change. They can also be able to speak to their fellow women. And I think, of course, it's the important thing bit is also to make sure that the health system, when they come to us, the supply side, we are ready for them to be able to provide all these beautiful interventions to minimize unnecessary death. Over.
Hello. Hello,
Hello.
I'm back.
Yes.
Okay, fine. So you lost me a bit, the network was fuzzy. So we're talking about self-care in prevention of anemia, right?
Yes, yes, and having a more holistic approach.
Okay. Yes, so in Malawi, when you talk comparing to like the socio-economic status also plays a big role in patients understanding the importance of some interventions. In antenatal care, there's antenatal education. People are taught about what is important, but some women will still not get it. Poverty plays a role. Even if you told them that you're supposed to eat this kind of food, if they are not able to afford it, there's nothing else that you can do about it. Unfortunately, we cannot treat poverty. But what we've noted, apart from the iron supplements, when it comes to intermittent preventative therapy using SP, the new approach right now is for women to actually take the medicines in the hospital while they are being observed. Because we noted that some women maybe might take it home, but not take it at all. So for now, the problem with iron supplementation, it has to be taken every day, so you can observe them at home. But with intermittent preventative therapy with sulfadoxine pyrimethamine, they are being observed in the hospital and by the nurses, so that they ensure that they are really taking the medicine.
Okay. Thank you very much. Joseph, do you have anything to add as regards this?
Yeah, just a little on what Gathari has said, that in Tanzania, we noticed some of the issues in the community, and we did also some of the root cause analysis. So we checked on the availability of the FEFO at the facility, but also the uptake through the routine data. We found the uptake was very high, but we were wondering what is happening in terms of actual practice of taking the pills. So we went further to the community and identify the issues, and then we found some of the myths regarding the use of iron folic. And then what we did is as I said, the community scorecard to those focal area with myths, so that the communities themselves, they can understand the importance of taking the pills, preventing the anemia, the area seeking in terms of care. So this has helped a lot to change the behavior, but also improving the situation. So I agree with the suggestion that we should not only medicalize the prevention or even the the whole issue of PPH, but also taking into holistic approach, looking into what is happening to the community and try to address using the available community health system strengthening models. Thank you.
Okay, we will take just 2 more questions, and I want to reroute the last one that I'm seeing here from Lalonde and ask it slightly differently. We have a devolved health system, which means the national informs what should be there as far as the policy and guideline direction is. But the health system really, the crux of commodity security and quality of drugs that are being used and quality of technologies that are being used that percolate right up to the grassroots in the communities within each county or province really is dictated by the procurement and supply logistics at the county and sub-county level. So my question is, in management of PPH, prevention and management of PPH, in prevention you have this armamentarium of uterotonics that are readily available, evidence-based, advised by the guideline. Unfortunately, and I think Dr. Durango alluded to this, does that guideline then get to inform the dissemination plan and therefore the implementation planning and eventual health system advisory for use? Specifically, Lalonde's question is therefore asking, do we have access to the condom tamponade or the UBT right up to the lowest level of care? Because even listening to the 3 of you, all of you have spoken towards a tertiary boost in terms of PPH. But are we getting it to the woman in the village at the lowest center that does offer maternity services? And if so, is there quality? If so, do you have capacitated staff to be able to actually provide that service? Any one of you can answer.
I can go first, this Gadari. Thank you, Anne. I think beautiful question and beautiful conversation, and I think very thought-provoking, so that we are not just talking, but you're actually, our talk is, we are walking the talk. And I do want to agree with you. We do at times face a lot of challenges, you know, sitting in settings where you're coming up with this nice conversation and nice documents and nice guidelines. But I think we must have a system that allows us to get them to the last point, you know, in the community. And this means first, in our dissemination, must be able to cater for all platforms that are possible, including, you know, simplified ways of disseminating them. And I think we, when you're talking about the PPH bundle, I think that's a beautiful way of going, so that you don't have to have a nurse who sees everybody at a health center having to figure out what to do next. Basically knowing that if a woman bleeds, these are the 3 things that I need to do. I think we need to do that, and also convert that to a solution that they can be able to access. You know, like in Kenya, you have a huge, a very high mobile phone penetration, and beginning to see what are some of these things that we can be able to convert to smartphone apps that provider can actually be able to access wherever it is that they are, so that then if they encounter a difficulty, they're able to provide the appropriate intervention. But in addition to that, being in a situation whereby they are actually able to have somebody who can mentor them, even if it's remotely, somebody who at least comes, even if it's reverse mentorship, you know, to come and train, that me as an obstetrician, I can find by time in the geography that I'm in to go to the last place and sit down with the nurse midwife, with the medical officers who are there, so that you can be able to build capacity of that. But I think the other bit also is to also link up with the population health, environment, and community resilience. We need to be able to identify in each community what are the priorities. Somebody mentioned about food. If you're not managing, you know, the population in relation to the health, to the environment, then you're going to continue having these challenges. So we must have those dialogues with our communities, being able to identify how do we do this together. And so making sure that whatever it is you're doing is centered around the community, the women themselves, so that we are co-creating interventions with them, not just coming up with our own ideas, but actually going down to them and finding out how can we help you? How can we be of help with you? What are your problems? And being able then to bring that to the fore. I think the other thing is that a lot of the countries that we work in is the governments are the custodians of health. I think also being able to put in systems that allow, you know, the leadership of the ministries of health, whether it's at the province or the county, to be able to step out of their offices in a friendly manner, being able to see what are some of the challenges that the workers are facing, being able to, you know, unlock those gaps with them, look at solutions together, and bring back to the leadership in terms of advocacy, being able to tell the leader, the political leader, or the person who allocates resources, including the treasuries. You know, these are the problems, and unless we do it this way, we are going to continue losing women and children unnecessarily. So being able to identify and galvanize those forces, including community members, so that you're able to bring, and that's why we're bringing up the element of social accountability at all levels, and not just at the community, but also even the leadership, being able to actually hold them to task. If we do not do this, we'll continue talking about these things, and I think we've talked about these things for so long, but I think as the health sector, we also need to step out of the health sector and think more broadly. What are the needs of that community? What are the needs of that household? And trying to look at how we can be able to bring all these pieces together and to have a louder voice. Thank you.
I will cut you there. Priscilla, do you have condom tamponade at the health center? Yes or no?
No, so not at the health center, unless it is a CMOC kind of, so community, we call them community health centers, which are CMOC centers, which have a theater setting. So those health centers are able to do that, but not a basic emergency obstetric care center, no.
Okay, Joseph, are you there?
Yes.
Do you have the Internet of Things? Are you still on manual records, or have you digitalized your records? Yes or no? The lowest level of care for maternity services.
The digitalized care is at the hospital level and the district level. So the lower level are still using the paper-based records.
Okay. Training. In your training, are you using the Internet of Things, or did COVID bring on the Internet of Things for you? Yes? No? We were? What were you doing?
For the digital learning platform, as I said, the service provider are using their mobile phone to access the module, and then they learn. They should be able to communicate with their mentors using their mobile phone. Yeah.
Okay, for any one of you, can you please answer this question as my last one? We've talked extensively on MPDSR, clinical audits. Audits are still questionable if they're high quality, but more so the response has been wanting once we have actually conducted the audit. It is very clear the frontline providers are principally midwives, clinical officers, and then the gynecologist as the last chain of command or hierarchical chain of command when you're dealing with the patient at the bench, which is at the bedside. Now, how many of us amongst the 3 countries have gone into process indicators as opposed to just looking at MPDSR? Any one of you, we're just measuring outcomes still, or are we actually even looking at process indicators which then reflect on quality of care?
Yeah, so yeah, for the Tanzania, the guideline also has some of the monitoring indicator in terms of the process, and just to mention, one of it was the proportion of deaths which have been reviewed on time. And yes, so we do have some of the process indicator at least to be able to monitor the process itself. So yeah, we triangulate with the other outcome indicator like institutional perinatal deaths or institutional maternal deaths that we are tracking on quarterly basis. Okay.
Malawi, anything you can comment?
In Malawi, we're in a process, so we're still reviewing our MPDSR documents. So in the new MPDSR, we'll have process indicators, but before it was just outcome indicators.
Okay, Kenya, Gadhari, keep it very brief.
I'll be very brief. I think, yes, we do, but I think the biggest challenge is and I want to speak for many of these countries, is the response bit of MPDSR. I think we talk, we do all those things, we identify the problem that I think response has been lacking and wanting. Over.
Okay, thank you very much. I must appreciate all our panelists, and I think the take-home message is Sub-Saharan Africa still has a long way to go in terms of addressing PPH as a direct cause of maternal mortality and morbidity, and by extension, perinatal and household and community. So therefore, the development agenda in any nation. We need to rethink prevention strategies. We need to rethink the recognition arm for PPH, and particularly, as somebody had spoken earlier, when you're dealing with a patient who's already anemic and then bleeds a little bit more and is pushed into PPH, or a lady who had a relatively good HB but was a high risk, or already a lady who has even had a previous history of PPH and therefore may actually have it recurring. The Internet of Things, we cannot run away from it. In fact, I long for the day we will even be able to embrace to the point of modeling to predict who is even going to end up having PPH. The other issue is now looking at collaborations, north-south, south-south. I think the language between different nations within the African continent would actually begin to articulate PPH slightly differently from even what we have been having as the North-South. And particularly when I look at the social cultural components and the social determinants that may be playing a role in our PPH. The other issue is capacitation. But with capacity building to give emergency services, what is the scope of practice? Therefore, what is the regulation? Therefore, how do you orchestrate an emergency team, and who compromises of that team set? And above all, what can we task shift and what can we task share when we're looking at the capacities to be able to rightfully prevent and manage PPH? The last thing is the private-public partnership. A lot of these innovations are coming from the private realm, and therefore even have a commercialized connotation to them. The question is, how do we then convert that to come into the public system and still be cost effective in that setup? So with that, ladies and gentlemen, I want to actually end this session. I hope you have a very wonderful time. And I want to extremely, extremely give my gratitude to the panelists who have actually given us insights on Tanzania, Malawi, and Kenya. Thank you very much.
Thank you.
You're welcome. So I'll hand back.
Yeah.
Yes.
Yeah, thank you so much. Yeah, thank you so much, Dr. Ann. And I echo your gratitude to and appreciation to the panelists, Joseph, Priscilla, and Katari, and Dr. Ann for you masterfully moderating.